Thank you. Very good afternoon to all of you, and welcome to the first CCR of this academic section. And at the outset, I would like to thank the Honorable Director, Dean, and Head of the Department of Surgical Disciplines for giving this newly created unit, Surgery Unit 5, the opportunity to present its first CCR. So I welcome you all to this CCR. Our case is a very simple case, very common surgery, very common complication seen after this surgery. But the patient had some unusual problems, and the treatment course was prolonged. But this case truly shows how the collaborative spirit of different departments works in the best interest of the patient. This case will be discussed by Dr. Nidhi, and Dr. Jasmine will be looking up discussing the literature. And the patient was operated by Dr. Subodh and Dr. Omprakash. Dr. Subodh, I think, is joining us, but Dr. Omprakash. Thank you.
Good afternoon, everyone. So to begin with our story, we have a young gentleman, 24 years age, farmer by occupation, presented to us in February 2024 from Jhansi, Uttar Pradesh, with complaints of pain in left upper abdomen for last 3 months and pain in left lower chest for last 1.5 months, associated with cough, scanty and thick sputum, occasionally containing blood. He also had a history of high-grade fever in this duration. On associated history, he took albendazole and ivermectin for 3 months before coming here. On examination, he was a young, poorly nourished gentleman with normal vitals, and on respiratory examination, there were 4 crepitations in left lower zone. And he also had moderate splenomegaly on abdomen palpation. On evaluation, his blood workup was normal. His chest X-ray and pulmonary function tests were normal. His serology was positive for echinococcus, and he presented with contrast enhanced CT of chest and abdomen done outside, which showed 5 × 5 centimeter hydrated cyst in left posterolateral basal segment of lung. Here we can see in this picture, where air foci were also there, which was suggestive of airway communication, likely rupture. And spleen also had 10 × 10 centimeter hydrated cyst in near the hilum. After thorough evaluation and optimization, he was taken up for surgery, where he was intubated using a double lumen endotracheal tube for single lung ventilation. And we started up with video assisted thoracoscopy. There were dense adhesions. Because of that, procedure was converted to open thoracotomy. And the cyst deroofing was done, which can be seen in the second picture. The cyst was opened and deroofing was done, followed by the cystobronchial communications were secured using non-absorbable sutures. And after this, the spleen hydrated open splenectomy was done. The histopathology report confirmed the diagnosis of splenic hydrated and lung hydrated. Now I call upon my senior Dr. Jasmine to discuss further post-operative course of the patient.
Good afternoon, everyone. I will take you through the post-operative course for this patient. So the surgery went well. The patient did not have any air leak intraoperatively. He was extubated and he was shifted to the high dependency unit. There, the patient was comfortable. He had stable vitals. But in the evening, when we did a chest X-ray, 4 hours post-operatively, to our utter surprise, there was a left lung collapse. While the ICD was still in place and column movement was present in the ICD. So now that we have a collapsed lung in the picture, we had to entertain 2 possibilities. One, the lung might not be getting aerated So there must be some obstruction to the airway, which could be either due to a mucus plug or a blood clot, which could have happened due to some injury during intubation. And the other possibility, which at this point of time was very less likely for us, was an air leak, but with a blockage in ICD. But the collar movement in ICD was present, so the ICD block was ruled out. So to explore the cause behind this, we shifted the patient to the ICU, where the patient was electively re-intubated and the critical care team performed a bronchoscopy. In that, it was found the left main bronchus was filled with blood clots. So these clots were evacuated and no active source of bleeding could be identified. As you can see, this was the blood clot which was occluding the left main bronchus. So post bronchoscopy, the morning after, we did a chest X-ray, the first one, where we could see the lung had expanded somewhat, but not satisfactorily. There was still a persistent lower lobe collapse. The ICD output was about 150 ml serosanguinous with present collar movement, and at this point of time, there was no air leak. In the morning, we repeated a bronchoscopy, which was normal, no further blood clots, no further obstruction, but a persistent collapse of the lower lobe. So we continued with our management. Patient remained intubated on the pressure support mode, and on the next day, we found, to our happiness and to our satisfaction, there was a gradually expanding left lung, and following which we decided to extubate the patient. So on that, after the patient was extubated, the chest X-ray was relatively fine. So we decided to remove the ICD. But as you can see, that after clamping the ICD prior to its removal, again there was a lung collapse, to our utter dismay. So immediately we declamped the ICD and an immediate lung re-expansion was noted on the chest X-ray. However, a new finding had come into the picture. That was a grade 1 air leak, which was present only on cuffing. So we kept the ICD open and we kept the patient under observation. Now the patient was extubated, but we found a recurrent lung collapse within the next 12 hours. So we decided, what could we do next? Maybe there was an air leak which was not being sufficiently drained by the ICD already in place. So we decided to put in another ICD. And we applied negative suction, which is the next line of management. So this negative suction basically ensures that the pleural and the visceral surfaces come opposed to each other and thus seal off the site of the air leak. So once we did that, we found that actually the air leak increased from grade 1 to grade 2 on negative suction. Because as we know that negative suction is kind of a double-edged sword. Sometimes it can cure a small leak, but sometimes it can also prolong that leak. So for this patient, we stopped applying negative suction at this point in time. As is seen in this video, the air leak has now increased. So next we decided to take the help of our friends in pulmonary medicine for a bronchoscopic localization of the air leak. I would now like to call upon Dr. Sujoy from pulmonary medicine to present the bronchoscopy findings.
Hello, thank you. So from pulmonary medicine side, when we have a lung that has collapsed along with an air leak, there are two things that we can do. One is we can look endobronchially and see, like they said, whether there's any mucus plug or clot. But now that the ICD is functional and there was a leak, we had to do, more importantly, do a leak localization. So I have a bronchial tree picture over here, and I have the video. I'll just play it for you. And for brevity, I've just kept the just the segments where the leak was localized to. So we're coming into the trachea. What we do is basically we go into each main bronchus and segment. Once we're in the segment, we either we kind of inflate a Fogarty balloon or an arm blocker, and we kind of block the segment. And when we block the segment, what we do is, so these are the basal segments of the left lower lobe. This is the balloon coming in, and we block the segment. So once we block the segment, we have the air leak that is happening. If it is a large air leak, we can directly observe that the air leak is reducing in the ICD tube visually. Or if it is a small leak, we ask the patient to cough, and on coughing, we can also make out whether the air leak is reducing or not. So we've blocked the more proximal bronchus, and once we do that, once we block the proximal bronchus and we see localize it to either a lobe or a segment, we go ahead more distally and we keep blocking the subsequent subsegments, and we try to find out where exactly the leak is. So this procedure might fail if there is a multiple sources of leak, but in this case, we could localize the leak to the lateral basal segment in the left lower lobe.
So now we have localized the leak. What next? So according to the American College of Chest Physicians and the British Thoracic Society guidelines, if following a lung surgery, the air leak persists beyond 4 days, or if there is a second occurrence of air leak after trying all other conservative methods, the next best treatment is going for a surgery. So that's what we did in this case. Generally, thoracoscopy is preferred according to these guidelines, but as we know, in the first instance, this patient underwent a VATS converted to open thoracotomy. So second time, we anticipate even more difficulty with thoracoscopy. So directly, we proceeded with a thoracotomy. So we re-explored the patient. This was 11 days following the primary surgery. Intraoperatively, we could find 3 sites of peripheral parenchymal leak, which were repaired using non-absorbable Prolene suture. But even after this, the lung did not expand satisfactorily intraoperatively, we performed a water submersion test, as you can see, where saline is instilled into the thoracic cavity and the lung is allowed to expand by manual positive pressure ventilation. So if there is a persistent leak, you could see small bubbles in the saline. Yes. So here we could see that there were no bubbling present, but the lung did not expand to our satisfaction. So we asked the anesthetist to perform an intra-bronchial lavage and suction so as to clear off all other mucus plugs, if any. Following which the lung did fully expand and there was no air leak on positive pressure ventilation. So after placing an ICD, we closed the thoracotomy. On the post-op day 0 following re-exploration and 11 days following the primary surgery, on the chest X-ray, we could find a full lung expansion, but the ICD still showed a grade 1 air leak on cuffing. This continued, but the lung remained expanded. On post-op day 2, that is after 48 hours, the chest X-ray also showed a lung collapse. So what next? What are the possible options that we can do right now? So it's never a one-man's army in medical science. It is always a team effort. So now we had to seek the help of the Department of Pulmonary Medicine and the Department of Interventional Radiology as to the further management. So what we could do was a repeat bronchoscopy and a glue injection, which could be either a fibrin or cyanoacrylate glue, or we could go ahead with a coil embolization. The other method was performing an autologous blood pleurodesis. We kept this option down in the list because once you perform this pleurodesis, it becomes difficult if we want to operate the patient later because of the adhesions that form after this procedure. And of course, the last standing option is reoperating the patient, but it has its own complications. The patient has already undergone thoracotomy twice. Obviously, it is much down the list right now. Right now, we performed a bronchoscopy on post-op day 15 following the primary surgery and 4 days after re-exploration. I would now like to call upon Dr. Joy to explain the glue injection.
So bronchoscopically, what we can do when we have an air leak that has been localized is we can block the segment from which the air leak is happening so as to prevent that from happening. So because they had already performed a repeat procedure from our last session of air leak localization, prior to glue installation, we had done a repeat localization procedure and we had localized it to, again, the basal segments of the left lower lobe. So this is the video I'm going to play is of the glue installation. What we're going to do so this is the segment, say that the air leak was localized to. Now, once we've localized the air segment, we insert a sheath bronchoscopically into the segment where we are interested in putting the glue into. So this sheath, the volume of the sheath is actually measured with saline prior to the procedure. So we are so as to know the volume of the sheath itself. Once we do that, once we insert the sheet, you can see the blue cyanoacrylate glue that will be injected into the desired segment. So this was the glue. And following the glue, we inject the same amount of volume of saline as the volume of the sheath, so as to make sure that all the glue has exited the sheath. Following this, we remove the scope and the sheath together so as to prevent scope damage, and then we clean the sheath and remove the scope. Following this, we again visualize the airway to see the glue cast. Here we can see that the glue cast has actually come slightly proximal to where we wanted it to be, and it is blocking the left lower lobe. So with our scope itself, we can kind of mold it into the segments that we want, and this is the final glue cast that we can see after molding. So this is the anterior basal segment of the left lower lobe, and the glue is kind of covering the lateral and the posterior basal segments of the left lower lobe. Following this, the air leak was actually visibly reduced once we asked the patient to come.
So after injecting glue, keeping our fingers crossed, we performed the next chest X-ray. On the chest X-ray, the lung was expanded, and there was a thin rim of pneumothorax, but given the series of events that has been happening until now, so we were happy with this lung expansion, and we are hoping that it will expand further. The next 2 days, however, there was a gradual increase in this pneumothorax, resulting in further lung collapse and the grade 1 air leak persisting. So now again we went back to our age-old option of repositioning the ICD and reapplication of negative suction. This time, on application of negative suction, there was no increase in air leak, so we continued it. And as you can see in this video, the patient is performing spirometry, and even on deep inspiration, there is no air leak. In the second video, you can see that the patient is counting numbers, and on normal expiration, the only air leak that was present was on cuffing or forceful expiration. This was the digital slow suction machine that we had used, and that was a set pressure. We set the pressure at around 10 to 12 millimeters of mercury. So after doing this, the chest X-ray, the successive chest X-ray showed that the lung was gradually expanding, but there was a persistent thin rim of lower zone pneumothorax. So we planned to go ahead with a low dose NCCT chest because the patient already had his fair share of radiation exposure. I would like to call upon Dr. Priya CTR to explain CT.
Good afternoon, everyone. So now we will see how interventional radiology helped to finally seal off this fistula that was persistent and the cause of air leak. So a non-contrast chest CT was performed. In the limited sections that I have shared in the lung window images in the minimal intensity projections, we can see that there is left-sided persistent pneumothorax as shown with the blue star and the persistent subsegmental bronchi in the post-op cavity, which are seen communicating with the pleural cavity here at least 2 sites, which is also seen in the coronal images. Even if we cannot see direct communication, the significant peripheral location of the segmental bronchi can be an indicator towards presence of a fistula. So after localizing the bronchopleural fistulas as peripheral subsegmental bronchi communicating with the pleural cavity, the patient was planned for fluoroscopy guided transbronchial coil embolization. So with the help of pulmonary medicine and the interventional radiology team, bronchoscope was inserted through the trachea into the left main bronchus, as we can see in the blue arrow. Then further, we used a Picard catheter to hook the left lower lobe bronchus. Further, we tried to negotiate into the subsegmental bronchi to see the leaks using the microcatheters. We could on the contrast film we could see the leak, but we were not able to negotiate the microcatheters. So previously placed glue cast was removed. As we had already discussed, the glue cast was placed using bronchoscopy, and after that we could cannulate the subsegmental bronchi, and 2 coils 1833 and 1855 were deployed. This is the run showing the deployment of the coil in the subsegmental bronchi of the posterior basal segmental bronchus of left lower lobe. So again, after placement of 2 coils, we took a contrast angiogram, but which again showed there is persistent leak
from the adjacent subsegmental bronchi as well as into the cavity communicating with the pleural space. So this is the run which showed. Then we decided to occlude the left segment, posterior segmental bronchus itself with two larger coils, that is 35, 14, 6 coils, which is shown with the green arrow. And the final bronchogram post placement of these larger coils showed normal opacification of the lateral basal and the anteromedial basal segmental bronchus and complete occlusion of the posterior basal segmental bronchus, sealing of the fistula completely, and the procedure was completely uneventful. Next, I would call Dr. Jasmine to share the recovery. So after the coil embolization, so we performed chest X-ray, and it was found that the lung had actually expanded and the coils were in situ. Over the next 7 days, due to God's grace, the chest X-ray showed a expanded left lung, and there was no air leak in the ICD as well, with present column movement. And clinically also, the patient had normal breath sounds which were equal bilaterally, and the chest X-ray confirmed the coils are still in position. Moving forward, after 7 days of coil embolization, we removed the ICD, which was about 36 days after the primary surgery. Post ICD removal, we observed the patient for 24 hours and then discharged him. He was followed up at 1 week and 3 months, both of which showed a fully expanded left lung with the coils in situ. So we have the final diagnosis of hydatid disease of the left lung and spleen with persistent postoperative air leak due to alveolo-pleural fistula arising from the subsegmental bronchi of the posterior basal segment of the left lung. Now I should present to you the review of literature regarding postoperative air leaks. This generally means a persistent escape of air, yes, sir, from the lung into the pleural space, and it's actually one of the most common complications following lung surgery with an incidence of 5 to 25%. So the implications being increased rates of hospital-acquired pneumonia, empyema, pneumothorax, pleural effusions, and respiratory failure, all of which contribute to increased morbidity and mortality. So persistent air leak is one that lasts longer than 5 to 7 days, which could be either an alveolo-pleural or a bronchopleural fistula based on which is the communicating segment of the bronchus with the pleura. Sarfolio gave this classification in 1998, grade 1 to 4, where grade 1 means present only on coughing, while grade 2 is on expiration, grade 3 on inspiration, and grade 4 is a continuous air leak, 98% of which are comprised by grade 1 and grade 2 air leaks. These are some of the risk factors. In our patient, the risk factors which were present were his poor nutritional status and intraoperatively dense pleural adhesions. So the management requires a clinical assessment and imaging by chest X-ray or CT. Intraoperative detection could be by the water submersion test or surfactant in case of VATS, and following which we can do a bronchoscopic defect localization followed by conservative versus operative management. So this is a simplified treatment algorithm. If the lung is expanded, well and good, no intervention. If not, post-operatively, we have to look for air leak in the drainage system. If present, we have to go for the management options that I'm going to describe. And if not, we have to do a bronchoscopy for mucus plug, a blood clot. Sequential balloon occlusion and methylene blue dye are the two methods of defect localization. These are the basic principles of management, most important of which are good chest physiotherapy and incentive spirometry and effective pain management, followed by chest tube management, negative suction, and other adjuncts as listed in this table, beginning with chemical pleurodesis, blood pleurodesis, endobronchial methods, and other miscellaneous options. These define the management based on the fistula diameter. Larger fistulas would require larger occluder devices which are used for septal defects or use of autologous fat pads. Coming to the indications of surgery, air leak persisting beyond 4 days or second occurrence, and the operative success rate ranges between 80 to 95%, but with its own additional operative risks. These are few innovative treatments regarding persistent air leak. So how can we prevent air leak? One is use of non-absorbables, which is intraoperatively, and coverage using fat pad or sheets. Now I would like to call upon Dr. Om Prakash.
Thank you, Dr. Jasmine. What about the unique in the or case? Young healthy male with no significant risk factor, grade 1 persistent air leak on cupping only, but enough to cause lung collapse. We tried all the method of non-operative and operative management. We have, and finally, coil embolization is worked. So, what is take-home message? Surgery is not the solution, but the beginning of the problem. And multidisciplinary team efforts are crucial to success. Personal commitment and persistent effort of treating doctor decide a patient's outcome. I thanks to Professor Madan from Colonial Medicine, Dr. Associate from Radiology, Anesthesia, Critical Care and Pain Management team, nursing staff and physiotherapist. Now, before we take the questions, I call to Professor Karan Madan for this session.
The take home message: surgery is not the end of the problem, it's the beginning of the problems, because Professor Mr. always used to say that with surgery you cannot solve everything. This we have written for the physicians. They have to understand. They say iski surgery karte ye theek ho jayega. No, that is not the answer. The answer may lie with Karan, may lie with Ashu said. But if surgery can be avoided, I think that is what one should try. Dr. Subodh, please. Then Dr. Karan and Dr. Ashu. So
I can only thank Dr. Karan and Dr. Ashu for bailing me out. This is one. And I think it's a true example of the team effort. And if you ask me, frankly, what was the reason for this persistent air leak and the collapse? Even the leak was not much, but it was the collapse, the recurrent collapse. And I discussed, I think I bothered Karan 100 times during his stay, and we discussed what is the reason. Because we do see a lot of patients in the trauma center with much more air leak than this, and they do not require any intervention. We just put the tube. There is a air leak, grade 1, 2, sometimes even 3 air leak, and if the lung is suspended after 4 or 5 days, tube is out, patient goes home. So, no, so that was, one is the disease, and I have operated many patients with the disease lung also. This is a very, that is why we presented also. Probably it could be multifactorial. One, if you see in the CT, in the HRCT, the course of the track was very curved course. There might be some the valve kind of a effect there. Second, the location of the leak is the posterior and medially. Third, because he underwent a surgery for the splenic hydatid also, so the movement of the diaphragm may be compromised. I really don't know. So some kind of a air trapped between the lung and the diaphragm, and which persisted for long. And I frankly, I don't have any answer to what happened in this case. Dr. Karan, please.
Thank you, sir. I hope that we are not required following a surgery. Everyone wants to know. Yeah. So no, but I think so. What I would like to highlight is we have some options for bronchoscopic closure of leaks, but I would say they are not very effective. For very large leaks, we can put large occluders, like for a large stump tear or something, which surgery is not possible. But for segmental leaks, if they're small leaks, glue and all work. I think what I would say is that for us also, it was good that we could collaborate with radiology and find, by problems come solutions. So you would say that you called 100 times. Because of that only, we got to, finding something way out. Then we combined, and we've done other cases also, in which we found that, if you combine IR with bronchoscopy, we can be more accurate at localizing these small peripheral leaks, which are much well localized using an interventional radiology approach. And I think that it's only for patient management and for betterment of patients. I think Dr. Ashu's comments also on this.
So you may say, you may ask that if coil embolization was to work so well, why didn't you do it earlier? So let me just tell you, it's not that it's standard of care. So what is the standard of care? There is none. That's the problem. If you saw the pneumothorax guidelines she showed you, there's one of 2001 and one of 2010. We haven't had a pneumothorax guideline since then because it's a very difficult condition to to treat peripheral bronchopleural alveolar pleural fistulas, and they're all anecdotal case series. So these coils are coils which we use actually for the vessels. They are not meant for non-vascular use. So it was an innovation that we had to do. And for a moment, we were scared that would it, erode out of the bronchus. But then we have done a few cases. We were stuck like this with a biliary pleural and bronchial fistula a couple of weeks prior to this case, wherein, what we were putting through the bronchus was coming out through the duodenum. We had a leak like that, and we did manage to seal it with coils. And so we decided to take a chance. It's an off-label use, but whatever cases few we have done, we haven't faced any issue with any of them.
Thank you. I think standard of care is AIIMS. It is the collaboration with the other departments that is the standard of care. Yes, sir. Yes, sir. Patience. That is.
Which is lacking. In 7 days, you are reoperating the patient. By 15 days, you are doing a lot of activity. Maybe if you just wait out a little longer, solve minor leaks.
Yeah, I think
and Madam said that we don't have series of large number of patients of minor leaks. It is because units that do this, they wait a long time for minor leaks.
I think I would like to respond to that. So if there is a ALE, you can wait for a month or 4 months, 3 months, doesn't matter, provided the lung is expanded. And there is a close approximation between the parietal and visceral pleura. But ALE with a persistent pneumothorax, you have to act.
You have to put another chest tube.
We did it. We put another tube. We applied.
If there is a major leak, then you need to intervene. Otherwise, you have to do it.
So we put another tube. We applied section, but did not work.
Pneumothorax.
It's wait and the patients get well, and the lung expands and they go home. So,
Pneumothorax.
I also congratulate Dr. Bansal sir that this is the first revision. I must also tell you that this is a newly created unit. Yeah, this is their first yes, here. So congratulations, you have a temporary ability.
I'm not taking up thoracic surgery, it is sports. So he only does thoracic surgery in a unit. Thank you. Thank you so much. Thank you for your patient hearing. Thank you.